we're going to get started here. We got about 45 minutes with these individuals, and so they're taking times away from their professional commitments to be here. So we want to be respectful of the time and the jobs that they have. I'd like to thank all the students who are here this morning. I know for many of you, you're waking up early on a Friday morning. We do appreciate you guys taking the time to visit. And we hope that you find this to be interesting and engaging. And again, as our presenters are talking, please feel free to throw something in the chat. And if I don't see it, Mr. Lloyd also is available to see the chat messages, and we'll be able to try to feed those into the queue. So to begin, what I thought we'd do is have each of our presenters do a quick introduction of themselves and sort of where they fit in the medical community, and if they also have a Norwin tie at all in their history. So we'll start with Shane. You're the upper leftmost person on my screen, so I guess we'll start with you.
Okay, sure. My name is Shane Spielvogel. I'm the executive director at North Huntington EMS Rescue. I've been here for almost 7 years, but my background is in nursing. I was a critical care and flight nurse for almost 18 years at UPMC before coming here. I'm responsible for the overall operation of the department. We cover all 32 square miles of North Huntington, doing about 5,000 medical incidents a year. And I manage a staff of about 30 different paramedics, nurses, and EMTs. And I do not have a Norwin tie. I'm an East Allegheny grad. So
East Allegheny, we're neighbors. Yeah. We're neighbors. Yeah. It's all good. So. All right, Taryn, you want to go next? Your microphone's still muted, by the way, if you didn't know.
I muted it. I am actually one of Shane's employees. I'm a paramedic rescue technician there. I've been there for about 5 years.
All right. And your Norwin connection?
Graduated in 2014.
Woo, class of 2014.
My brother is a senior this year.
Ryan. All right, Teresa.
Hi guys. Good morning. My name is Teresa Luchetti. I am a Norwin grad of way back in the day of 2001. And my background, as well as Shane's, is in nursing. I am a nurse. I've been a nurse for 12 years. I started out at Presbyterian Hospital doing critical care work in their ICUs, mainly focused on neurotrauma, so head trauma and spinal cord injuries. And then I spent 5 years at McKeesport Hospital, running their critical care units over there. And then I recently came back to Presbyterian Hospital, UPMC Presby, to oversee their neurotrauma ICU, again, intensive care unit, as well as their surgical trauma ICU. So the two main trauma ICUs of Presby, as well as the code team. So I oversee about 123 nurses and patient care techs right now. And my unit it's never a dull day. So I interact with, so we saw a lot of people from in my McKeesport days from both Shane and Taryn's place. And so it's good to have a full circle with here in the connection.
Awesome. Thank you very much. And again, if you guys are not familiar too, the dashing gentleman in the upper right corner of my screen again is Mr. Lloyd. He is our honors biology teacher at the high school. So if you're, I know the stream is open to middle school students. So if you're not familiar with Mr. Lloyd, you may meet him in the near future. So he also teaches scuba, just for the record. He tries to work that in. So let's just start. If there's no questions already from what we have in there, why don't we start? If each of you could share briefly. Since the theme of this is COVID-19, what's in terms of your professional lives, what's been the biggest change that's occurred? If you can summarize just one, I'm sure there's a bunch. But what's been the biggest impact on your professional career of the COVID-19 pandemic? And it doesn't matter which order we start in, it's fine. We're going to let Shane go first again because we're polite. Go ahead, Shane. That's fine. Okay. Gentlemen first.
Sure. I think the biggest change for the staff here at Rescue Wade has been, as emergency responders, we're used to kind of identifying problems and mitigating them very quickly in the field, and that's what we specialize in. One of the biggest issues for us has been adapting to ever-changing information. And so working with local, state, federal partners to get updates and then to use those updates in practice. The biggest one being the increased amount of personal protective gear that we're using and the amount of staff medical surveillance that we're doing to our own people. So it's unusual for us to come in and do temperatures and body checks on each other for health before a shift, but that's where we are now. In addition to treating every one of the patients that we come in contact with as if they potentially are infected, and kind of varying degrees of gear use based on patient presentation. One of the other things that we're dealing with too is, as we identify people in the field that are potentially infected and they go through a series of screenings with us, ramping up and down the amount of gear that we're using, so you can see Teresa's wearing a face shield there. If we were with a patient, we'd be doing the exact same thing, and we would ramp that up and down depending. There's a lot of other things too we could get into about changes in medical procedures in the field, the way that we treat respiratory patients out in the ambulances. But I think the one constant has been change. So, we are adapting daily to new information that's received from a number of sources. And trying to sort that out is probably the most challenging portion of all of this.
Good. That's awesome answer, Shane. Thanks. There's a lot. I'm sure we can follow up on that. Taryn, you want to add to that, being more on the front line then?
Yeah, I would just agree with Shane. Is even in the very beginning of all this happening, there was so much change, and trying to keep up with it almost multiple times a day, there would be different things coming in, different things that we have to do. And I agree with either ramping up or ramping down our PPE depending on the patient was difficult as well. But I think everybody's starting to adjust to it well.
Thank you. Teresa, from a more hospital-based standpoint, probably echo a lot of the same.
Oh, absolutely. Every day there was multiple changes, at least 5 times a day. There was, at the beginning, I was sending out communications on a daily basis of just what the new changes were related to the personal protective equipment, of what we're supposed to wear with certain patients. At first, we weren't treating everyone as if they were a positive patient. If they had the virus, that quickly changed so that you just assume that that you have to. And so that changes the whole perspective of things, especially in the hospital as nurses and physicians that are in here. If someone isn't doing very well and, they suddenly crash, that our initial instincts is to immediately go in and help them as quick as we can. But during a pandemic, there is no emergency with a pandemic in the hospital. And so our first priority was to really kind of protect ourselves as staff, and to make sure that, we're fully protected before we go in and care for patients. And that's been one of the hardest things that myself and my staff have been trying to get into, because we're always just in the trauma world. We live for the unknown and what's coming in through the door, and to kind of put a pause to make sure that, we're caring for ourselves has been a really big change for a lot of people.
I can imagine. Yeah. Playing off that, I know, and there was a question that came in from chat too, so I'm gonna do a double question for you guys too, so I make sure to get that in. Based on what you guys were saying, and from all your perspectives, question number one would be, has it? And again, I don't really know what a normal day is like before the pandemic, but it sounds to me like you've had to rely a lot more on decisions made at state and national levels than you guys might be used to. Has that been frustrating, having to wait or get approval or get validation from higher levels, or has that always been there and I just don't know about that? So that's question number one. Has it been more challenging working as part of a bigger chain? And a question came in from David Emro about the numbers. Have you guys seen the numbers going up, going down? So I'll throw both those out at the same time.
So EMS operates off of a protocol-based system. One main difference as working in the field versus working in a hospital is in the field, you base a lot of what you're doing on protocolized, right? So you're not going to have a physician based over your shoulder giving you orders, or even like in the next room where you could quickly call for them. You have to operate independently. It has been somewhat challenging, some guidance that's come down from, we get our medical command guidance from the state. It's filtered through local hospitals. So we have changed some practice. It hasn't been so much frustrating as it has been challenging. You want to make sure that you're following the appropriate, most recent guidance about different procedures. So I don't think it's, we haven't had to really wait for permission on a lot of things. It's more been about just making sure that what we're doing in practice is what's in line with the most recent recommendations. And that's been a thing for us. The numbers, I'll tell you, for North Huntington EMS, our overall call volume is down. The amount of people that we're seeing that are calling 911 is down by about 30%. But the acuity of those people, how sick they are, the ones that we are seeing are sicker. I think people are waiting longer to go to a hospital and trying to manage some diseases in the home that maybe they would have sought care for earlier, for fear of going into a hospital and maybe catching something there. And, I don't think that's a real thing. And I'll let Teresa kind of address how the hospitals are addressing making sure people are safe there. But so the people that we are seeing, while it's less people in the field, they are sicker. We have seen a number of people that we suspected, at least on their presentation for us, was COVID positive, but only a very, very small number of those people were actually COVID positive for us. So numbers are down. Sickness is more. People are more sick than what we normally see. And the biggest challenge really is keeping up with change.
Taryn, on the in the front line in the ambulance, what's your perspective on that then too?
I will agree with Shane that people are a lot sicker. I do believe people are waiting to call an ambulance more so than what they normally would if this whole pandemic wasn't going on. I do believe people are afraid of going to the hospital and possibly catching the coronavirus. Yeah, I would agree. People are definitely, when they are calling, they are a lot more sicker than what normally we are seeing.
And when you're interacting with them, like in person, do you feel a sense of a more administrative burden then, trying to make sure you're following all the most recent protocols too, and making sure you're doing everything the state and the government's been asking you to do?
I don't feel like I have like an administrative burden on myself when doing this. I know my ultimate goal is to protect myself so I don't contract it myself and bring it home to my family. So I'm happy to oblige by whatever new things are coming down the line. I know we're very cautious and we do ask certain questions in order to be able to know whether or not what level of PPE we have to wear at that time.
All right. Thank you. And then Teresa, from the hospital environment then, Shane thought you some similar feelings
absolutely. As well? So with UPMC as being a system, there's kind of the model in place right now is that, so there's less transfers between hospitals. And so like Presby we've been at a 50% vacancy pretty much since the middle of March because of this, because for similar reasons, like people are choosing whether or not that they truly need to come to the emergency room or come into the hospital. Less people are out and about, so there's less car accidents.
If I could interrupt for a second, can you put 50% vacancy in like a context? Like what would your norm, sure. and vacancy would mean also for kids that don't understand what the vacancy rate would be.
So Presbyterian can fit about 670-ish patients in their rooms. And so we've been at right around in the 300s patients in rooms for the past couple weeks. Our ICUs, I have about 134 ICU beds, so the sickest of the sick, and we've been running with like around 70 people in those beds for there. So Presby's a little bit bigger, and the ability to treat patients where they need to be instead of like a community hospital, such as like East or McKeesport or Excella, where there's 1 or 2 ICUs there that see everyone and everyone. And beforehand, like if they had a really bad heart attack or a really bad stroke, or they were shot or had a really bad head injury, they would get shipped to Presby to be taken care of for those specialties. But people aren't out and about doing those things. And if they're suspected with having COVID and they're at one of those outlying hospitals, they're not being transferred to Presby. And so that really puts a strain on the local resources in the area. In the ICUs that, you know, may only have 4 ICU beds, but they have 16 patients with COVID in it, it's a little bit more taxing on the staff and on the patients and family members at those local hospitals, versus where at Presby, we've been prepared and ready for people to come in. My biggest unit was a trauma unit that we had, and we emptied out that unit to be prepared for a potential surge for COVID patients that we were seeing in New York, and, you know, coming into having a plan prior to it getting that bad. Luckily, the Pittsburgh area has managed to flatten the curve up to this point, and so we've been able to take care of all of those patients that have come in without exceeding the resources that we have with both equipment and staff. So.
Good.
I don't know if that makes sense.
No, it makes a lot of sense. No, yeah. And again, any students who are you know, in the stream too, feel free to throw your questions in chat, and we'll try to get to them yeah, as soon as we can in the queue.
And point to the point where about patients being afraid to come into the hospital. So we've taken some steps to make sure that, you know, we do our part with not spreading the disease. If you know you don't have any symptoms and you may have it. And so that is like one of the things. So we implemented the universal masking. And so it doesn't really, this mask that I have on doesn't protect myself, but it's the same concept that you have when you go into Giant Eagle, that, you know, you're protecting the other person that you have, so that if you may have it, you're not spreading it, less likely to spread it to somebody else. And so that's, everyone in the hospital that comes in now has to wear a mask, or you're not allowed in. That's even patients when they go from like room to room.
All right. I know, you know, if when you open your news feed, you see this, you know, every day, you know, in the top headlines and stuff like that. From your guys' perspectives, is there an aspect of this story that you feel hasn't really been covered in the news, or is there some sort of impact that you feel maybe isn't more widely known or appreciated?
I think the one thing that we've been really concerned about here is the general health maintenance of the population. So we deal in waves, you know, so we have busy seasons and less busy seasons, and those kind of go hand in hand with like seasonal trauma, or October to December is a really heavy kind of like influenza season where we see folks. And because people are hunkered in so much and not traveling, and physician offices are not seeing people in the doctor's offices for their maintenance visits and kind of normal care, the one concern that we have thought about here that was not really come out yet, and we're wondering when it's going to, is that, you know, we have a significant elderly population in Western Pennsylvania. And so we're worried that some of these older folks who may or may not have some fear about going to physician offices or clinics or just general maintenance of health are kind of suffering at home a little bit, maybe kind of toughing out through some situations that they shouldn't be, or should be seeking help for. And so I think that's a big thing. So if you know, one of the things we try to do is to encourage folks to check in on elderly or at-risk neighbors or families, just to call them and even say, you know, is there something I can do for you? Some way I can help you to either get something into your house that you don't have, or to get you somewhere, or to offer reassurance. I think a big concern that we are kind of like just whistling past the graveyard with is just general health maintenance. and especially with the at-risk and elderly populations in the area.
Good point. Good point. Either you guys want to add to that or come up with your own like untold aspect? Like, in Taryn, you've probably seen, you know, in terms of like, I thought it was interesting, like you mentioned, Taryn, that you're seeing different kinds of people in the, out of curiosity, Taryn, like, are you seeing less like, I assume you get called for like industrial accidents and things like people like cutting themselves with a chainsaw and stuff like that. Are you seeing like a different type of acts? I mean, are we just simply having less like work-related accidents and more just I'm sick accidents and stuff like that? Is the ratio shifted for you?
I don't really notice like a specific ratio that is shifting. I will say with a lot of people staying home and not actually working, I'm sure that is cutting down on the amount of industrial accidents, so to say. We still get them because there are people that are still working, but it's difficult to establish the ratio with the stay-at-home order.
Mm-hmm. Teresa, anything from the hospital environment? Anything flying under the radar?
I think the biggest thing is that the people still are coming to the hospital, and there's still people that are there, and they're still really sick. And, you know, the hospitals in the area have this no visitor policy unless the person's actually dying. And so that's really hard on families, on patients, on staff. I mean, the emotional toll of like being there when it's like the end of life for a lot of people and there's literally no one there, and we're FaceTiming people with an iPad or having a Zoom meeting with family discussing, you know, what's going to happen to their loved one. I think it's like that people part there that hasn't really been there. It's the connection to humanity that, you know, we're trying to adapt with, but it's still really hard for those people that, you know, you go into healthcare to help people and you really feel like you're not doing your job to the best of the ability when you can't actually physically be there for people.
Do you feel patients in the ICU are sympathetic to the fact that they're, I mean, it's got to be hard, again, if you're sort of end of life and you're not allowed to have your family there with you. Are they understanding? Is it a, you know, are they able to, or is it frustrating for them too? Is it an extra stress for them, or?
Well, they're not really aware of it. So it's more like for the family members that have to make those decisions. And a lot of times people, I mean, you can probably think of an idea of like if someone told you that, you know, your grandma wasn't doing so well, like what does not so well mean? Without physically being able to see that person, it makes it really difficult to, you know, be comfortable with yourself as the decision maker to like see that it's the best thing for them, or that if it's something that they would want to do. So it's not necessarily the patients in the ICU, it's the family members that are making those decisions because you can't see what's going on with it. I mean, it's just like you and I right now having this Zoom conversation of having a difficult end of life conversation with somebody. It's just not, it's not warm and fuzzy. But for the most part, everyone has the best in mind for when they're caring for their loved one. And so sometimes it's a simple thing of, you know, I may not go as Teresa, like my name may be Jim to everyone else in my life, in my familyhood. And if the nurses are calling me Teresa and I'm not really understanding it, who they're talking to, like you don't have that connection of my like in-laws or someone there telling me like, oh, she doesn't go by Teresa. She always goes by Jim. We don't know why, but you know, it's kind of there. So you lose that kind of personal connection. And that's part of one of my goals, that I still make my staff feel like, you know, the patients are people and not just, you know, like a body or numbers on a monitor. Without families, it's, you know, they bring us into reality a lot. So.
Yeah, like they bring in the family photos and the stuff like that. So yeah, absolutely.
Yep.
Good. All right. Well, while you guys were talking, we had a couple student questions come in. There was a question from, let's see, it was from Addison, and she had a question about the hours that you guys put in, like maybe how many hours you would typically put in, and has that changed with the COVID-19 situation? like in a typical, the specific question was like a typical work day for you, and has that changed with COVID-19? Or, but give some context, like what's a normal day for you, and then what's a COVID-19 day?
Taryn, scare them and give them your schedule.
Okay. So I work 24-hour shifts every Tuesday and Saturday. It does change to shift to 20 hours. So sometimes I do get off at 3 a.m. and other times I will work 7 a.m. to 7 a.m. And it has not changed from the coronavirus. I've done this since I've started working here. So I get my 40 hours done in 2 days.
We talked about this a little before the meeting too. Can you share with the kids what a 24-hour schedule actually looks like in practice?
So now with the coronavirus, my shift starts at 7 a.m. I will go in. I have to take my temperature, fill out a questionnaire, make sure everything like that is all good, that I'm still okay to work. We just have to make sure there's more PPE on the ambulances. So I make sure I have my N95, my gown, my eye protection. We have face shields now to wear as well. And like I said, those are all just different levels that we can get up to depending on the patients. And then we do just regular stuff around the station, like station chores and stuff like that, wait for calls to come in. As calls come in, we will respond to them. Paperwork as normal, charting.
One important, like they are allowed to sleep, so it's they aren't up for 24 hours straight. They're allowed to take naps. They're allowed to go to bed at night. They just have to get up for calls. Lots of coffee, but their downtime is still their downtime, so they can do what they need to do. Administratively, for me, I still work Monday through Friday. I have a 24-hour call schedule at home, so I live in the township now. I have a take-home vehicle from the department, but a lot more administrative details, more meetings. This is more of one of the fun ones that I've done. A lot of sitting through seminars and webinars, a lot of off-hour calls for questions from other public service agencies. Us and the North Huntington Police are very close. So the police chief, Chief Rizzo, will call with, hey, listen, one of our officers arrested somebody and they did this. Do we need to quarantine the officer? Do we have to, do this or do those kinds of things? So for me, as an administrator for Rescue 8, operationally going on calls, probably less. But administratively, developing policies, keeping the staff informed, doing in-station training, making sure that we're healthy and able to respond is probably 50% more easily, depending on the week.
Yeah, I would echo those thoughts, Shane. So the nurses on the floor, they work 12-hour shifts, so they start at 7 a.m. or 7 p.m. So that hasn't really changed. There's not been that much overtime per se with us in the Pittsburgh area. There's been more roles to make people safe. And so when we do have a positive COVID patient or even a person that we're ruling out, we have an extra nurse there that has an eyes on the staff coming out of that room to make sure that they doff all of their personal protective equipment in a way that they don't recontaminate themselves. And so we've added a little bit of extra layers of security and safety for the staff that normally we wouldn't have. Those roles didn't exist prior to COVID, and so that's with their part. The nurses part didn't really change that much. Similar to Shane with the administrative part, I was involved in a lot more decision-making skills on what to do for the system level of how to treat patients. My medical director works really closely with each other to make sure that, we're able to, because as I mentioned before, there's no emergency in a pandemic. And so we had to come up with, step-by-step processes of whether or not, if the patient looks like they're having problems breathing, that, you want to just be proactive in your responses to them, and so that you're not putting yourself at risk. And so an example of that, people like to put in a breathing tube prior to them needing it in the past, where like 3 weeks ago, if they were having a little bit of problem breathing, we wouldn't necessarily jump right to a breathing tube. But because we know that COVID is aerosolized and there's more issues related to the safety of staff, when you do it emergently, we do it proactively now. And the same thing of just the care of the patient after that point. You know, there's more of a step-by-step things that you're looking for. So it's neat in a way that it's more laid out for you of how to care for a patient, but also kind of scary too that they can get sick really, really fast and really sick really fast.
Okay. Okay, thanks. No, it was nice to see the perspective from all you guys on that. There were two questions. I'm going to combine them together because they're both sort of deal with the same question. Both Ali and Arnav both asked in terms of staffing in general. Ali was wondering, is there a shortage of workers? Have you seen more people going into it, or people dropping out? And Arnav as well asked in terms of do you see colleagues taking a leave of absence? Are there some people that don't want to be in that environment, or people getting sick and or having to leave and care for loved ones and things like that? Have you guys seen the staffing / hiring end of things impacted? I would imagine maybe are more people like interested in going into the field now, or I guess it's kind of hard to say in terms of the dynamics and stuff like that, but do you see it driving people away, bringing people towards you? You losing people, gaining people? What's the impact on your employment situations?
If I could add to that before they answer too. Also, there's been mention of healthcare people moving to more hot areas like New York and so forth. Have you seen much of that from this area?
So EMS-wise, we're on a hiring freeze because it wouldn't be fair to that person to bring them in right now and get them oriented correctly while we're in this kind of a crazy mode. Part of the reason that we are doing all the medical surveillance of our staff, like Taryn mentioned, questionnaires and temperatures, is to make sure that we're healthy enough to work. So we have had 2 staff members here that were on quarantine, one for a week, one for 2 weeks. Both were tested, both came back negative. Nobody was infected. And currently we are running at 100% staff. So we don't have the shortage we anticipated when this first started of, when this first came around, we thought that EMS volume, hospital volume, we would be similar to what's being seen in New York State, New York City. A crushing of resources, loss of providers because of infection or quarantine, and really, I think because of people following the social distancing and restrictions, we have kind of really swung that the other direction. So we have gone to a much lower census. We are taking more precautions, and so I think we're operating in a more safe environment. As far as the EMS world, the emergency services, not seeing people shy away from it. We're not really the type to really kind of back off from things. And there are people that are taking up what's called a travel contract and going to some of these hot spots, or working in a critical environment to make one big sum of money in a short period of time at a pretty high amount of risk to themselves. And that's a choice that every professional has to make at some point in their career. And that's the same. They're recruiting EMTs and paramedics and nurses in places like New York City, Las Vegas, and a couple others, Philadelphia area. So we are not seeing a reduction in staff, thank goodness, and currently not taking anybody new in.
So nursing is a little different. My unit was on the shorter staff side to begin with when this all started. And in the ICU world, travel, a lot of people come in and like use nursing as stepping stone sometimes to go and be travel nurses. And so we did, between Presby and Shadyside, there was about 30 nurses that did go to do travel assignments that were in the hotspots areas, whereas like echoing Shane of a ridiculous amount of money per week, where some people could, essentially have their 1 year salary in like 2 months worth of time. So some people did go to that. We managed a lot of people did want to return after that. And so like one of my staff members, he really wanted to go out there. And the plan is for him, you know, to come back. He's still on like my payroll. And so when he comes back, he just has to quarantine himself for 2 weeks, self-quarantine, and then, you know, to pick up after that happens. So there was a big deal of drawing people for the travel part. Quarantine wise, with like our staff being exposed, like we do a lot of the same things. So before we go into work, we do have to answer questions about if we've been exposed to anybody or if we have a cough or fever, and they do check our temperature as well prior to coming in. And so it's the same thing. The staff are the most important part so that we can care for our patients. We have to be healthy ourselves. At the beginning, there was a lot more exposures or potential exposures before like we decided to test a lot of patients. And so my code team was really impacted by that because they would go in and, you know, like be a part of the code response prior to the physicians deciding that they wanted to test this person for COVID for like 5 hours beforehand. And then they go and they were swabbed and they came back positive. So then anyone in those rooms for the past like 2 days worth, you know, you had a contact trace of who was exposed, how long were you in the room, were you within a certain distance of the patient, what were you doing, and it was determined upon whether or not they needed to be quarantined for the 2 weeks time frame. And so it was more so at the beginning with code response, and then we modified our procedures so that all codes are treated as if they're a COVID patient so that we have that protection. But it is that balance between the important part is just making sure that we have the equipment, like the protective, the masks and the gowns and the eye shields for people. We are not on a hiring freeze. I've actually hired 9 people within this time frame, and they're going to start between the end of May and the end of June. About half of them are new grads because people have been going to school. You know, if you're after college or after high school and you want to go into nursing school, there's these nursing students that are graduating at the end of the month. And, you know, their last semester was kind of wonky depending upon which school they were with their clinical hours and stuff. So they need jobs and I still need staff. So we've hired a good bit of people that have had contact with us throughout their years of being in school. And so they're ready to start in June for those people that are graduating. Orientation's been a little bit interesting because, you know, we want to try to conserve the protective equipment, and so we don't have an orientee in those rooms, and so they're just getting ICU training in another ICU, but they've done a really great job with that, and the team's been awesome, and the staff's really just been working hard to, you know, keep each other safe. There's a really great camaraderie that we've seen, and if an individual themselves, you know, were a person at risk, we have accommodations for them so that they don't have to put themselves in danger while working in the hospital. So we were able to accommodate them.
Good. All right, I know we blocked you guys off for around this time limit. I'm gonna wrap up with one more question, and then I know you guys, you know, have your professional responsibilities to get back to. But before I forget, there was a request from Mr. Navy, and I'm sure echoed from a lot of other individuals in the chat stream. Just that they wanted to express their thanks to all you guys for what you're doing. You know, we appreciate all the challenges and learning and stress that you've had to go through to do your job and keep doing it when a lot of us are at home on our couches. So we appreciate you guys doing what you're doing. Not that teaching from home is easy. Can I tell you, it is not. Mr. Lloyd Beck, it is rigorous. It is not easy at all. All right. So one last question, and although this is a fairly large and open-ended question, there was a question from Arnav with respects of looking ahead. You know, everybody has already been kind of stressed out by the stay-at-home orders and stuff like that. People are, you know, you can see in the news media and stuff like that, there's a lot of people itching to get, you know, the country back started again and stuff like that. From a medical perspective, and again, this is all hypothetical, and obviously things on the ground can change. Your guys' perspective from a medical standpoint, you know, what are we looking towards maybe within the next, you know, hard to say what's going to be happening in September, but, you know, where do you see us going regionally, maybe over the next month or two? What can people maybe think to expect is going to be happening here? And then we'll wrap up on that question.
So I can tell you from Westmoreland County perspective, dealing with the Department of Public Safety and the Westmoreland County partners, we feel like, based on numbers and the way that it looks in the county right now, we're on the downside of this. But how long that downside will last, how far of a slide really is it, right? So I think you're going to start to see over the next month to 6 weeks a slow kind of return to some kind of a normal. But I don't think that's going to mean that we're going to flip it right back into prior life. There will still likely be some kinds of cautions, some restrictions, some things that are new will become normal. And I think that might be things like one-way grocery aisles and, some other kinds of ideas. But I think you're going to see also, as we head through, think forward, think through the spring into the summer. And then once you start to get into the fall, when you have your normal flu season around October-ish, I think you're going to see a greater awareness of people wanting to take appropriate flu precautions. And hopefully, in a year or so, we might even have a vaccine for this novel virus. But in a year's time, there could be the next novel virus. So we don't know what's going to happen. But, I think medically and society-wise, I think you're going to start to see a slow return to normal for the summer months. But I would just urge everybody to be cautious and evaluate things as they happen. Let's not push too far too fast. I think the greatest example I've heard is about parachuting, right? Parachute slows your descent. You wouldn't cut the cords at 100 feet because you were close to the ground. You would take it all the way in. So I think that's what I would advocate for.
Yep.
Taryn, what do you see the next couple months being like for you?
I mean, I agree with Shane. I hope people still follow like the CDC's recommendations and staying at home and washing their hands and everything like that. I would hate to see people start to try to return to normal too soon, and then we see a spike in people that are actually infected because they're trying to get out and do things, and when they should really be staying home. I get it that warmer months are ahead of us and everybody wants to be outside and doing things, but I would still hope that people follow the recommendations and kind of wait to return back to normal.
Thanks. Taryn or Teresa?
Yeah, absolutely. The parachute quote is one of my favorite lines that Shane had. It's still going to be slow. It's not going to be a rush open procedure until we know who all has been infected and in contact with it. I mean, that's the only way that you can kind of deem it safe to go back. And so I'm curious and looking hopeful towards the different antibiotic tests that are out there so that you can at least determine some people of, hey, you're safe to go out and about and you won't cause harm to anybody else. Because that's the scariest part right now, is that if you show no signs and symptoms, but you have it, you have the potential to hurt somebody really bad. So take it slow, wash your hands, cover your mouth. Washing hands is a big thing. So that's,
yeah.
slow.
I did see in an article, basically the theme of the article was that, we haven't really solved anything yet. The virus is still as dangerous as it was before. Basically, all we have done is tamp down the initial wave of infections, and that it's the metaphor is basically we're sort of in a dry field right now, and there were some fires, and we've managed to stomp out a lot of those fires, but we're still standing in the middle of a dry field. And you throw a couple of matches in there, and everything starts back up again. So the idea is that as we reopen, in whatever form that takes, I think people are maybe going into it with like a little too much. We haven't solved it. We don't have the vaccine yet. Some people have gotten sick and some people have gotten immunity, but we're not, as a country, really any less vulnerable than we were before. We're just sort of reset the clock, and hopefully we can proceed forward with a lot less incidents and stuff like that. So
Yeah,
Yeah.
I think you also could be looking at like herd immunity at some point too.
can
It's
you
just
do a
the-
30-second explanation of herd immunity for the?
Sure. Yeah, herd immunity is where a certain number of the population become infected and develop immunity, and then you kind of it just goes away. Like, everyone gets the common cold right now, and it doesn't really affect you as much, doesn't really turn into too much of it.
I did read an article the other week that said I think they estimated in New York that through everything that's gone on in New York City, I think they've estimated still only 15% of the people in New York caught it. So I think they, and again, that was just a headline I saw. I didn't read much more of the article. So there's still a lot of vulnerability out there in a lot of communities though. So that's awesome. Hey, I know, and again, you guys booked that time away for us, and I want to thank you for that. We do very much, again, appreciate your time here this morning. And we appreciate your time, all the time you're not in front of a camera. Again, you guys are doing the real work, and we appreciate all the learning that went into where you are right now, and what you're going to be able to do to help us get through this. So, and with that, I'd like to thank our speakers for being here. I'd like to thank Mr. Lloyd for riding shotgun with me on this. I appreciate his assistance, and to all the kids that are again in the stream, we appreciate what you guys are doing too. We know this is a lot of times the nurses and the shopkeepers and everybody on the front line gets the accolades, which they well deserve, but it's hard doing what you guys are doing too. And the fact that you guys are staying home and following directions and resisting the temptation to go hang out with your friends, it may not seem like very dramatic or exciting, but if you guys don't do your job, you make it harder for all these individuals to do their job. So your smart decisions are just as important, and you can make these people's lives a lot easier by following the best current practices that we have available to us. So thanks for what you're doing.
Thanks for having me on. It was a good time.
No, we appreciate it.
Yeah.
Thanks again. Thanks
Thanks for having us.
All right, guys, stay safe. And I'm gonna turn off the meeting here. So I appreciate everyone who tuned in, and
Have a good day.
Take care, everyone.
thanks. All right.
Have a good one, guys. Stay safe.